Uh,
Good evening and a warm welcome to all the dignitaries present here. I'm Sreushi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by the Indian Medical Association Medical Students Network, and the focus of today's session is History Taking Episode 3. So let's begin today's session, for which I would like to invite Dr. Gaurav Jaidev sir to take over. Sir, please proceed with the talk.
Okay, thank you so much. A very good evening to everyone who joined us today. The Indian Medical Association is glad to present to you with collaboration with AMBOSS and ClearNet, a live webinar session on clinical examination where seasoned healthcare professional and a student who is beginning a journey to assess and evaluate a clinical examination, which is a cornerstone for patient care. It combines medical knowledge, practical skills, and art of patient interaction and to provide better patient prognosis. In this session, we'll be exploring the key components of clinical examination, focusing on the techniques and tips which will be required for your practical examination. Our goal is to enhance your proficiency and also give you a focused assessment for a specialized examination. Now, as you prepare to get inspired and enlightened, let us dive into this engaging session by welcoming Dr. Mehak Chima ma'am. Dr. Mehak Chima is a VMMC and Safdarjung Hospital, New Delhi alumni. She has presented the United Nations in New York, WHO in Geneva, and multiple conferences around the world. With over 300 hours experience in training medical students, she is now in as a partnership with AMBOSS in India. Her passion to improve medical education for medical students is well known. And so we're thrilled to have ma'am who will be taking the spotlight for session. Welcome aboard, ma'am, and thank you so much for joining in. It's all yours now.
Hello, everyone. Thank you so much for the very warm welcome. I'm Dr. Mehak Chima, and I'm very happy to be here today. I hope all of you attended the past two sessions as well, but today is going to be a continuation of that. So our next session is going to be a continuation of clinical examination, but today I wanted to do something a little different, something we don't talk about enough in Indian medical schools, but it's very important, not only from the point of view as a student, but also a couple of other reasons. One of them is, of course, that it's very commonly asked in vivas, but we don't practice it enough. We don't know about it enough to answer about this. Second, if you plan to go abroad, if you plan to take any exam, even NEET in the upcoming future, a lot of questions from this topic are usually asked, but we don't know how to approach them simply because we're not taught about them enough. The topic I'm talking about is medical ethics. And why are we talking about medical ethics in history taking and clinical examination? It's because, as we discussed yesterday, in the last session, when does clinical examination start? It starts from the point of time that a patient walks into your office or into the hospital, or the first point when you see a patient. That's exactly when ethics start as well. Medical ethics guide every single thing you do in the hospital. But because we don't talk about them enough, it's almost considered कि ये तो सबको आता ही होगा. That's not true. Medical ethics follows certain pillars, certain guidelines, and different rules in different countries. While we're not going to get into the laws into a very deep content, because of course you'll study that in forensic medicine, we'll talk more about the practical application of ethics and how do you approach certain situations. So how this session is going to go about is, first I'm going to talk a little bit about medical ethics and what are they based on. Then we'll talk a little bit about situations in which ethics arise. And in the last section, we're going to talk about certain approaches, certain, again, scenarios in which you might have to apply these ethics and how you can go about them. All right. So I'm going to start off right away and share my screen. One thing I will say is that if you have any question at all, please do ask. This is a topic that we don't discuss enough in med school, which is why a lot of times you won't find the right space to ask questions about it. But here I will try my absolute best to answer these. Of course, my answers are based not only on everything that we're going to discuss and what we study, but largely also what I've seen in the hospital. As it was already mentioned, I'm from Safdarjung Hospital, Delhi. So I had the privilege of seeing a lot of patients, a lot of cases, and I'd love to share some of those experiences with you. All right, so I'm going to start sharing now, and we're going to first look into the principles of medical law and ethics. One thing I want you to understand is that medical law differs from country to country. However, ethics don't necessarily differ. The reason for that is because what are medical ethics? Medical ethics is essentially a set of core principles that we need to respect patients as individuals. We need to understand that even in a hospital that is very busy, even if you're seeing 100 patients in a day, you are the only doctor a patient has. You might have 100 patients, but the patient doesn't have 100 doctors, which is why how you provide healthcare is very, very crucial. And I want you to understand this now, because the earlier you understand this, the better doctors you will become. Now, going into the principles of medical ethics, there are 4 main principles that we need to take care of. And I want you to remember that these are words, nahi hai, they are things that you actually need to follow. All right. So, one is autonomy. Autonomy means that the patient deserves and has a right to know about everything that is happening. What I mean here is put yourself in the same situation. If you were about to get a surgery and I said, you're getting a surgery, that's it. I don't tell you anything else about it. I don't tell you why I'm going to operate on you, how I'm going to do it, what can happen. You're not really going to enjoy this entire experience. You're already scared. You're already in a position when you don't know what's happening. And if I don't tell you what's happening, that's even worse. What's worse is if I don't even ask you for your consent. If I take you, operate you, and say, I'm done. Doesn't work that way. You have to ask for consent. Apart from autonomy, there's beneficence, which means that everything you do has to be in the best interest of the patient, not of the hospital, not of the finances, but of the patient. Next, non-maleficence, which means that you have to avoid causing injury or suffering to the patient. Now, this may conflict with beneficence, but that's why we always have a ratio of good to bad. So how much good can we do to the patient in this scenario? All right. But at the end of the day, we have to avoid causing any kind of injury or suffering to the patient. And this is we often talk about this in case of drugs and surgical procedures. An example I'll give you is a surgical procedure might be required, but if it's not going to do much positive for the patient, but might do more harm, then you wouldn't want to proceed with that. Lastly is justice. Of course, you have to treat patients fairly and equitably. Equity is not the same as equality. Equity and equality are 2 terms that we've now been discussing a lot in global health platforms like, again, WHO and United Nations. They're very different. Equality means everyone should be treated the same, but that's not true. Everyone can never be treated the same. Equity means that everyone should deserve what they have the right to. That is equity, which means that if I have the right to healthcare, I should get my right to healthcare. That is what equity means. My right to healthcare might be different from someone else's in the US, but what I deserve here is what I should get. That is equity. And that's why patients should have access to both equity and equality, of course, but we talk more about equity. Apart from that, we talk about principle of proportionality. Principle of proportionality is exactly what I talked about, how you have to understand your intervention's potential benefits, and they should be proportionally greater than the harm, which means, I'll give you an example. If there is an elderly patient and they have a neurological cancer, right? One of the only ways to actually treat this cancer or to be able to properly diagnose this cancer would be through a biopsy or would be through something invasive. However, in this case, when the patient is already, say, above the age of 60, 70, or 80, doing an invasive procedure might cause more harm than benefit. Because if the body is not going to be able to tolerate such a procedure, then what was the point? Moreover, this is going to put them under financial, emotional, familial burden. And that's where the principle of proportionality comes into place. I hope that within the first 10 minutes, you've now understood that medicine is not just medicine. When we say ki for XYZ disease, you have to give XYZ medicine, it's not as simple as that. If a patient comes to you, you realize that they are a patient, an individual, a human being, which means that your medical ethics are not only dependent on what you want to do, but what they think is right for them and the proportion of both. All right. So our aim is to minimize patient harm proportionately to maximizing treatment efficiency. All right. One of them is also one thing where we talk about ethics a lot, and this is something you might see in psychiatry or in medicine, is physical restraints. I don't know if any of you have been to your medicine wards or your psychiatric wards yet, but patients are often restrained. The reason for this is something like, say, alcohol liver disease. Okay. In alcoholic liver disease, patients have neuropathies, which is why they might even go into a situation like schizophrenia. With schizophrenia, you can imagine if they have a Ryle's tube in place, if they have a catheter, if any situation at all, they have the situation of harming themselves. They can harm themselves, they can pull out the cannula, they can pull out their Ryle's tube and injure vital organs as well, which is why we have to use physical restraints. That's where the topic of ethics comes into place. Because in this case, physical restraints make sense. However, if a patient is completely conscious, they are well aware of their situation, but you give them physical restraints to do something without their consent, that is not an ethical situation, right? So ethics always exist in the gray. It is never black and it is never white. It is always in the gray, which is why it's judged from situation to situation. Medical ethics are the kind of thing where I can never tell you, this is what you're supposed to do no matter what. No, it cannot be that way because it has to depend from situation to situation, which is why medical ethics is such a fast growing and spoken about topic, right? Now, apart from that, of course, we have medical laws as well. I'm not going to go into the depth of medical laws because they vary from country to country. Within India as well, it depends on what you're talking about. We have different abortion laws from a lot of countries. We have different laws on euthanasia as compared to a lot of countries. Involuntary commitment, all of this is pretty different. The one thing that is not different, though, is, again, consent. And from consent, I'm going to move on to ethics of communicating medical information. Now, the reason we talk about ethics of communicating medical information is because at the hospital, I agree, in most Indian hospitals, everything is very fast paced. You have one doctor who's responsible for 20, 30, 40, 50 patients. How can they take care of each and every patient? But it comes back to this. You are their only doctor. If you don't give them information, no one else will. You know, this happens a lot when we're sitting in the OPD, patients come in and they've searched things on Google and you're very angry. You ask them, why, if you wanted to search it on Google, why did you come to me in the first place? But you need to understand it from a patient's point of view as well. When the doctor is too busy to explain them anything, they have to go to Google because they don't have the books that you have. They don't have the knowledge that you have. So where else will they understand what's happening to them? You are their source of information, right? So what do we know about ethics of communicating medical information? First thing is full disclosure. That means that the patients have right to medical disclosure, full medical disclosure. This, of course, means that you have to tell them what you're going to be doing, why are you doing it, what kind of, so for example, in a surgery, you have to tell them what is their situation, what does the surgery look like, what are the most common post-operative complications, and you have to answer their questions. You cannot leave them with this information and say, deal with it. You can understand the kind of psychological harm that can cause. Apart from that, disclosure of medical errors. I understand that we're living in a time right now where even the topic of medical ethics seems very gray. With all the kind of violence against doctors that's happening, with everything that is happening around us, it is scary. However, again, you need to remember, the patients deserve to know what's happening to them. Because whenever you're in this doubt about whether or not I should tell them, put yourself in that position. Put yourself in a position where you would like to know. You would like to know what's happening to the relative. If your mother was in a hospital, would you like to know what's happening to her? You probably would. That's why disclosure of medical errors becomes very important. I'm going to hope that most of you don't come across a situation where there was a medical error by yourself or by another provider. However, unfortunately, most of us will come through some or the other situation that has something like this, which is why you have to disclose medical errors. Apart from that, confidentiality. Confidentiality is again something that proves itself with autonomy and privacy. Confidentiality is important because this is something that's often talked about in ethics, actually. We talk about confidentiality mostly when we talk about minors, when we talk about something that should we reveal this to the family, should we not reveal this to the family. One more part where this becomes very important is a question we got in the past 2 sessions, that is sexual history taking. Sexual history taking is also one of those situations where privacy and confidentiality become very, very important. Because if the patient is not comfortable with their situation being exposed, with their situation being told to other people, it is your responsibility as a doctor to maintain confidentiality. All right. Of course, there are some special exclusions. For example, when it's a medical legal case in MLCs, you have to reveal everything. It is your responsibility to the court to reveal everything. If the person might endanger the public, apart from that, there's notification of diseases. So, for example, if a patient comes with COVID, you have to report COVID because it comes under notification of diseases. And if the patient has any kind of, if they might commit violence, if they might endanger themselves or someone else's life. This is where there are some exceptions to confidentiality. But now that we've heard all about different pillars of ethics, why do we need ethics, all of that, I'm going to dive into a few special situations. So challenging clinical and ethical scenarios. Let's talk about this for a little bit. This session in general is not going to be a full 1 hour session because I want to leave space to ask a lot of questions and get answers from you. So whenever I ask a question, if you'd like to answer, you can type in the chat box, and then we'll do a couple of questions as well for the people who answer those questions. Of course, you're going to get free AMBOSS like we did last session, right? So patient-physician relationships. Let's look at this one. Yeah, self-treatment. So for example, in a situation where a close friend asks you to prescribe oral contraceptives before going on vacation, because she forgot to ask her physician for a refill. This in general is not very appropriate for India. The reason for that is because we don't do refills here. We don't have one physician, we have multiple physicians. But the reason I would ask you to not do this is because without someone's clinical history, do not prescribe them medication. It does not matter if it's oral contraceptives or oral antibiotics. Please take the patient's full history before doing anything at all. One thing that is very, very common in India is someone tells you, "Mujhe sar dard ho raha hai, I have a headache," and you give them a medication. You do not know if they're allergic to ibuprofen, if they're allergic to diclofenac, if they're allergic to paracetamol. This could lead you into much deeper trouble than you think, which is why your answer to "I have a problem" can never be a one-word answer. You have to take history no matter what, even for something as small as a cold, because believe it or not, there are people who are even allergic to cetirizine, something that we very commonly give for a common cold or any kind of allergy, right? So something like accepting gifts. This is very common. In general, this does fall under medical ethics. I request you all to be very, very careful when accepting gifts from patients, from the industry. This is very common. Let's look into autonomy. So, an adult patient refuses treatment because of their religious beliefs. This is a very common question that usually comes in, I'd say, MLE, but also in India. Now we're talking about it a lot in community medicine. So when a patient, and I'll give you an example. So right now, Navratri is happening, right? And a lot of people in India are vegetarians. However, a lot of medication, especially capsules, have a gel coating on them. When something has a gel coating, there is a chance that it might have animal fats in it. If a patient tells you, "I will not take this medication because I'm vegetarian and this medication has animal fats," or "I'm fasting and I cannot take medication," will you force them to have medication? No. You cannot force a patient to have medication, be it because of their religious beliefs, because of their cultural beliefs, because of anything at all. Your responsibility is not to make sure that the patient has their medication. It is to make sure that the patient knows the best possible treatment options for them. All right. Apart from this, let's look at one more. A patient's spouse or family member wants information about the patient's disease course. Now, this becomes a little complicated. One, if the patient has approved, they've given their consent, you can definitely explain information if you have their consent. If you do not have their consent, you cannot explain this to the family. The reason for that is, again, in history taking, you're not taking their history with their family. What does their family look like? What does their family dynamic look like? So it is very important to understand that before disclosing a patient's history, you need to take their consent. All right. Apart from that, say during shared decision making. So for example, a patient requests a non-emergency treatment or procedure that conflicts with your personal or religious beliefs. This one I'd say is very important. The reason it's important is because I'm not sure if you've noticed already, we're talking about a topic, something like abortion. So abortion might be against your personal or religious beliefs. Does that mean that if a patient comes to you and asks for an abortion, you'll say no? Not necessarily. You can inform them that this is against my beliefs, but you can also put them on to another doctor. What you're not supposed to do here is moral policing. I'll give you an example. I was in the US this year in February, and as some of you might know, might not know, US has very strict abortion laws. And I was in Arizona, Phoenix, which itself has very strong abortion laws. Now, there was a patient who came to me and she said that the doctor who was treating her, not only did the doctor refuse to perform an abortion, even though it was legal according to the number of weeks, they even forced her and tried to convince her to keep the child. She did not have the financial status to keep the child. Her partner was not available. But the doctor tried to convince the patient that you should keep the child because abortion is wrong. God hates abortion. Now, I understand if it is against your religious beliefs and personal beliefs. However, it is ethically completely wrong to try to convince the patient of something as a doctor. You simply cannot do that, or a nurse or any kind of healthcare professional. Apart from that, if a patient requests an unnecessary intervention, it becomes very important to understand why the patient wants this unnecessary intervention. Simply refusing the patient is not good. The reason for that is because you might refuse them because you know this intervention is unnecessary, but they can go to another doctor and get it done. So explaining to them why it is unnecessary becomes very important. So we have some other scenarios here as well. You can all go through these scenarios in your own time. They're actually really wonderful scenarios. A lot of them are more complicated than you think. With ethics, as I said, because we're not taught about ethics, because we don't do scenarios in case ethics come along, we often think this is what I would do. That might not be correct. That might not be medically or ethically correct, which is why it becomes very important to go through these scenarios. All right, what we're going to do now is a couple of questions. Before we do the questions, would anyone like to ask me anything? And if not, then we'll quickly jump into the Q bank. And yep, let's take a look at a couple of questions. Right. So in a question like this, I hope you're all able to see the question. So a 65-year-old man is brought to the emergency department by his wife because of a 3-day history of severe right-sided flank pain, fever, and vomiting. He has a history of gout, benign prostate hyperplasia, and type 2 diabetes mellitus treated with allopurinol, tamsulosin, and metformin. Very standard medications we use. Urine analysis shows pyuria, leukocyturia, and WBC casts. The results of blood and urine cultures are pending. The patient is diagnosed with pyelonephritis and admitted for empiric treatment with broad-spectrum antibiotics. After 4 days, his symptoms have continued to worsen. He is somnolent and not oriented to person, place, or time. Again, all of these things are things you're getting because you took proper history. Temperature is 39 degrees Celsius. Pulse is 130 per minute, respirations are 24 per minute, and blood pressure is 60 by 30. He is transferred to intensive care and vasopressor therapy is initiated. The physician informs the patient's wife that her husband has developed urosepsis as a complication of his urinary tract infection and that advanced life support might be necessary. A written advance directive provided by the patient's primary care physician includes a do not intubate order, which was verbally confirmed by the patient. There is no medical power of attorney. The patient's wife says she wants full life support in case of cardiorespiratory arrest. Which of the following is the most appropriate response? I want you to understand something here. The problem is that the patient said they have a do not intubate order right here, which means that they asked not to have full life support. However, the patient's wife says that she wants full life support. So there is a clash there, and that's where ethics come into place. So now you have a couple of options. What do you think your answer will be? You can tell me whatever you think your answer will be. And yep. So the first option is, if you can confirm that this decision is in your husband's best interest, I will provide full life support. I can only intubate your husband if you obtain a court order to revoke his advance directive. I will perform cardiopulmonary resuscitation if needed, but I cannot intubate your husband. This may be difficult for you, but your request is unethical. You should respect your husband's wishes. I have to respect your husband's wishes and will only provide comfort measures. Looking at these options, you can understand that every single thing you can say means something very different. All 5 options are, of course, still said in a nice way. They're not being mean through any of the options, but they all mean very different things. So you have to choose your words very, very carefully when it comes to ethics. All right, do we have any answers? Any options? All right, we have C. Perfect. Yes, C is the correct option. So a living will is a legal document that expresses a patient's wishes. What's very important here is that you have to keep in mind that just because the attendant is asking for something, you cannot give that, because at the end of the day, it is the patient's wishes that you have to take care of. Thank you so much for answering. If you could also send me your email ID, I will give you access to Amboss for 1 month. Let's look at one more question. Perfect. Okay. A 36-year-old woman is brought to the emergency department by her sister 1 hour after she was found unconscious at home. She appears lethargic. Her temperature is 37 degrees Celsius. Pulse is 80 per minute. Respirations are 5 per minute. And blood pressure is 120 by 70. Urine toxicology screening is positive for alcohol, benzos, and barbiturates. The patient's condition improves with supportive treatment, and she's admitted for psychiatric evaluation. 3 days later, a physician colleague approaches the physician who treated the patient in the lobby of the hospital and states, I just want to know what happened. I'm her neighbor and childhood friend, and I'm worried about her. Which of the following responses by the treating physician is the most appropriate? You can find the information in the electronic medical record or files in your hospital. Why don't you go ahead and ask her directly? She's currently in the psychiatric ward. Her urine toxicology screening was positive for alcohol, benzos, and barbiturates. I'm not the right person to ask. Please ask her primary care physician. I understand your concern, but I'm unable to provide the situation. Let's go to my office to discuss the situation privately. So what do we think is the right answer here? All right. Yes, perfect. That is the right answer. So this comes down to, again, as we discussed, that when a patient comes to you with, when the attendants or someone the patient knows wants to know about the situation, it really comes to the fact about whether or not the patient would like their information to be disclosed. So correct, that is correct. Can you give me your email ID as well so I can send you access to the Amboss platform? And that is all we have for now. This was a shorter session. Again, ethics, even though it's a very, very long topic, I would love for you to know more about it yourself and get into each of these situations yourself, because as you can see, the options are usually very close. But when you take a deeper look, when you try to understand what's happening, that's when you get a hang of it. And you need to do at least 20, 30 questions to be able to get the hang of it. So super. Thank you so much, everyone. If anyone has any questions, please feel free to reach out to me. My email ID is also in the chat box. So if you'd like to ask me questions, you can definitely do that. And yeah, thank you so much.
Thank you so much, ma'am, for the session. I feel like you mentioned that ethics it might be a very small topic, but again, that forms a cornerstone to any healthcare approach, whether being a student or a doctor. So it is a very informative session. And to proceed with the vote of thanks, I would like to express a heartfelt thanks to speaker Dr. Mehak Cheema, ma'am, who took time out from busy schedule. On behalf of the entire organizing committee for sharing your experience and knowledge. It's a great matter of pride, ma'am, to have you on the panel and enlighten us all of us here. Last but not the least, I would like to thank our pillars of the podcast, Dr. R.V. Ashokan, sir, who's National President at IMA Headquarters, Dr. Anil Nayak, sir, the Honorary Secretary at IMA MSN, Dr. Shalabh Gupta, sir, the National Chairman, Dr. Akshay Yadav, sir, the National Convener, Dr. Arjit Bhatt, sir, National Convener of IMA MSN, and Dr. Pritish Nair, who is the Joint Secretary in Academics and member of the Research Committee. And our digital partner for today, ClearNet, and along with Amboss as well. Do check out their content as well. This podcast would not have been possible without the support and the questions. We just put it in as a collaboration of everyone's hard work here. I would once again thank you for attending the session. If you have any input from your end, you could share. Okay, so I think that's all for the session today. I hope to see you all in the next episode with another precious faculty coming over and an important topic. Till then, stay tuned. Thank you so much, ma'am.
Thank you so much, sir. Thank you so much, ma'am. Thank you so much, everyone, for giving us the opportunity to host the session. So with all your permission, I'm closing the session over here for today. Thank you.